Sure, we're very happy and honored to share some of our data about the kidney-sparing treatment for the UTAC patients. As currently recommended by the EAU guidelines, only low-risk UTAC patients can have the option of receiving kidney-sparing treatment. However, like in the real-world practice, and frequently encountering patients who has the solitary kidney or bilateral tumors, or the patient has severe CKD that's we're facing the risk of dialysis after the radical nephrectomy. So we are applying a clinical trial and incorporating local treatments and systemic treatments for tumor control to achieve the kidney sparing with the high-risk patients. So we got two trials. One trial is using the RC48, the HER2 ADC, combining with the PD-1 immunocheckpoint inhibitor, combined with the endoscopic laser ablation in selected cohorts of the localized high-risk UTAC patients. So we included 31 patients, all high risk with HER2 positive. So combining with the disitamab vedotin, which is the what we call it DV or RC48, with the PD-1, combine both with the endoscopic laser ablation. So 31 patients with the median follow-up of 24 months follow-up, and the conversion-free survival was for 1 year is 91% and 2 years is 88.9%. So with the help of the systemic treatments, most of the patients were able to maintain their kidney. So I think it's at least it's an alternative option for patients with the solitary kidney or bladder tumors. And it also shows that even in high-risk UTAC patients, there is a certain selected cohort of the patients that we were able to spare their kidneys.
Yeah, so it is a multi-center randomized study focusing on patients with non-muscle invasive bladder cancer. We included 350 patients randomized to en bloc resection, so removal of tumor in one piece versus a conventional resection. So in the past, we tend to resect in a top-down approach or a piecemeal manner. So the idea is that by removing the tumor in one piece, we want to reduce the floating tumor cells, reduce the chance of reimplantation, and also ensure a complete tumor resection, because in the past it's just based on the surgeon's bare vision, but now we can look into the resection margin. So basically, we found that en bloc resection could reduce the 1-year recurrence rate from 38.1% to 28.5%. But more importantly, I think we also found that patients with low risk intermediate risk disease, then surgery alone is very beneficial. And for high-risk disease, surgical approach is just one part, because you want to minimize the chance of residual disease for implantation. But high-risk disease also is about the tumor biology, like a high-grade cancer, multifocal disease, carcinoma in situ, etc. So in high-risk disease, we found that patients receiving en bloc resection plus BCG, actually the 1-year recurrence rate is very low at around 5%, and 2 years is about 10%. So basically, I think as a urologist, doing a good surgery is the first step. And in high-risk diseases, in particular, a good surgery plus a good adjuvant actually can be a cure for most patients with high-risk non-muscle invasive bladder cancer. And we're really happy that we got this award, EAU Best Award, and it represents the hard work of all the centers in Hong Kong. And I actually really look forward to working with Professor Bao, and in future for those UTAC trials. I'm sure we can do a lot of meaningful work. We can influence international practice.
Yeah, and I also like to say this prize means a lot for, I think, for both Dr. Teoh and for all the Chinese urologists. There is actually, if you see in the audience in the EAU concert, there is a board with a list of all the award-winning papers and prizes, and Dr. Teoh's paper was like right in the middle of that board. And the first thing I was in the audience, I was taking the picture of that prize, and that's my favorite pictures of all day. So I mean, it's actually not easy to conduct RCT with surgical trials and with positive trials. If you think about all the techniques RCTs, like the monopolar versus bipolar TURP, or open versus laparoscopic versus robotic surgery. Not that many controlled trials can yield a positive result. I think like one of the issue would be the heterogeneity of the surgical techniques between different surgeons, especially in our trials. I mean, 13 hospitals in Hong Kong and different levels, different patient volumes, and of course, different surgical experiences of the surgeons. So, like, what is your experiences of like doing quality control and unified surgical techniques among all the surgeons?
I think it all comes to the quality of your randomized study. So to begin with, obviously, you need to make sure that all the surgeons are well trained, right, to do a new technique. And secondly, you need to make sure that the whole study protocol or the subsequent management is all standardized. And of course, standardized follow-up period. And the thing is, bladder cancer is such a heterogeneous disease. So in a way, if you just change one treatment, but if you fail to control the other parts of the whole management pathway, then most likely the effect will be diluted and ending up with a negative result. So you're right. I mean, if we plan for a surgical trial, the quality check is very important. Making sure that everything else is controlled is equally important, and maybe you can come up with a very good result.
Yeah.
But I really look forward. I mean, with different centers in China, because we, have many patients. I really believe we have the capability in running trials. So look forward to planning studies together, doing trials together, and hopefully we can create some really meaningful work for many others to follow.
Yeah. I really like the paper. Like the first time when I read the paper, I just refer the paper to all the members in our department, and everybody knows the paper.
Yeah.
And when we talk about M-block resection previously, we always say good technique but sparse evidence.
Yes.
But now we're going to change our slides.
Sure.
Now we have a high quality evidence.
Yeah.
For sure, you're going to be cited for the guidelines, and for sure, everybody in the future learning the techniques will learn the paper. So again, we have a good sum up for the trial, and I would sincerely say congratulations for Dr. Teoh for conducting such a great trial.
Thank you very much. Yeah. So I think without a doubt, organ-sparing approach or bladder-sparing treatment is going to be the future. And the thing is how we can plan for a good pathway, clinical pathway, to make sure that we select the right patients, we offer the right treatment, and then follow up accordingly. And in the past, it's very challenging because in the past, we don't have a good way in terms of patient selection. Now we're doing more imaging, for example, MRI scan, not only preoperatively, but also postoperatively, so we can have an idea, whether there is still any disease in the bladder. And secondly, in the past, when we do a conventional resection, especially for large tumors, many surgeons might just do a so-called staging TURBT. So there's a gross residual disease at the base. But if you really want to embrace bladder-sparing treatment, actually from the very beginning, we need to do a good resection, a maximal resection, or even in the context of envelope resection, we do modified approaches, right? Achieving a maximal resection as much as we can.
Yep.
And then finally, we're still not there yet, but we're trying to look for biomarkers to predict systemic response. So if you look into PO01 study, there are some biomarkers seems to be predicting a response after pembrolizumab. Evidence is still very limited, but imagine if you have a big tumor, you have a good resection, all these tissue can be tested, you have a biomarker predict which kind of systemic treatment is going to work. And then finally will be what you have mentioned, the ctDNA, because obviously you want to give maybe 1 year or 2 years of treatment, but then probably you will follow up with ctDNA and see whether you can stop the treatment, or if there's any case it changes from a ctDNA negative status to become a positive status, then probably representing a minimal residual disease, then you might need to restart the treatment. So I think the game now is still out there because no one has defined the whole pathway, but we pretty much has every element that is needed to have a good bladder-sparing pathway. So we're in a position to
Right.
plan for good studies on this.
Yeah, I strongly agree with Dr. Teoh that the UTDNA, ctDNA is definitely going to be one of the future directions that we will be working on. And now we just need more data, and we need more scientific tools to further distinguish the role and how we should distinguish those thresholds. One of the issues that we were having for now is that the technique has been evolving so quickly, and we always have new tools and new techniques coming in. But the way to analyze or doing the statistical analysis with the data actually comes slower. Now we have a lot of sequencing data, but we don't have the perfect statistical tools to do the data analysis. Sequencing data, we call it compositional data. That all the data were in a closed oscillating space. So it's different from the traditional data than it is in the open space. So for those compositional data, we need a unique statistical way to do the analysis. If you choose using the traditional statistical way, it will have a high risk of having the false positive results. So again, the question would be, we know it's the future, but we just need more data, more technique, and more statistical ways to tell me what is the best thing in the future.
I think the thing that you mentioned is very thought-provoking because people have tried to use mostly RNA sequencing data to classify different so-called subtypes of bladder cancer. But the problem is, you can divide into different subtypes, but it has really limited implication as to what type of treatment that you give, because the data is not based on treatment response. But that will only be possible if we have longer term data, if we have a cohort with bladder cancer or UTUG, we have the specimen sequencing data, and then we give chemo or give IO drug, and then we know the response. Then maybe based on the response, we can kind of work out which molecular features can point towards a particular treatment. And this is what we really need, I think, in globally, because we have so limited data in this regard.
Yeah, I mean, it's the statisticians' job to develop new statistical ways, but it's our urologist's role to conduct more trials and generate more data, and especially data representing the Chinese patient cohort. So we essentially hope that we will follow Dr. Zhang to lead more Chinese urologist initiated trials, that further contribute those data.
Work together.
Yeah. Well, I mean, it's ctDNA. From my personal point of view, it's a great option. It's a great alternative options for the DNA testing, because when we're talking about the timing of the DNA sequencing, there's a lot of occasions that you would make the decision to do the DNA sequencing or the gene test when the patient is entering the mCRPC phase. And this is the time usually the patient has been receiving the systemic therapy for, let's say, 3 to 5 years and the MHSPC stage. So when you look back to their original systemic biopsy samples, usually the sample has been degraded and the quality may be suboptimal for the DNA test. So sometimes you're trying to do the rebiopsy again, but sometimes the prostate can not always generate a positive biopsy, or just the tumor may not be representative for those drug-resistant lesions.
Sure.
And sometimes you're trying to aim for the metastatic lesions, but sometimes it's bone lesions or it's the lymph node in the perineal regions that is pretty difficult for you to get the sample. So what can you do? And those point of time, you have a ctDNA, you just need a blood sample we call the liquid biopsy. That makes the things much easier. So as you can see, the current data has shown that the ctDNA has a very good representation comparing to the tissue biopsy. So personally, I think it's a good tool. The only issue I am aware is that as for the DNA repair gene, is that ctDNA sometimes misses the homologous BRCA2 deletion. We call it BRCA2 home zone. So both of the BRCA2 genes were gone. Then in that case, if you're doing a ctDNA, you can see any mutations of the BRCA2, but it's complete deletion. So usually the BRCA2 home cell patients actually get the best responses for the PARP inhibitors, but you sometimes just miss it in the genes. But that's a rare occasions. In most occasions, I think the ctDNA is a great role for testing.
So I think in the context of a metastatic disease, so the tumor volume is generally larger, and most of the time we can detect some CTC, and that's probably also why in the PROPEL study, actually the majority of the patients were screened to be CTC positive, and obviously it's easier to just take blood rather than going back to the biopsy sample or rebiopsy. It's really tough. So I fully agree. I mean, CTC should be considered in the patients, but of course, in some really difficult situations, biopsy is something that we can consider in selected patients. And I think in our locality, especially in the status of mCRPC, because you are gradually running out of options, so this is certainly something that we will consider testing and also offering a treatment. Or in patients with a very strong family history of prostate cancer, or young patients with prostate cancer, sometimes we tend to test for this HRR mutation and then offer this treatment as well. I think as mentioned, especially in advanced status, we tend to test for this mutation. And also in patients with young patients, even less than 60 years old, 50 something, you have prostate cancer, or you have a extraordinary or atypical type of histology, like a ductal type of prostate cancer, or when you have a very strong family history, say your sibling or your parent, your father has prostate cancer, first degree relative, then we tend to test for this type of mutation and then treat accordingly. And certainly a combination or use of PARP inhibitor, I think is very well accepted in terms of the utility, and the side effects profiles are quite easy to manage as well. So this is the current status in Hong Kong.
Yeah, I strongly agree with Dr. Teoh. And usually in the mainland China, the most common scenario when you are talking with the patient about the DNA testing would be the time when the patient was entering the mCRPC phase. And there are certain occasions that we would talk with the patient to discuss the possibility of doing an early DNA test, even in the at the time of diagnosis. That's as Dr. Teoh says, it includes the young patients younger than 60 years old, or the patient with a very clear family history. And sometimes, like we're currently running a clinical trial to see the rate of DNA mutation with the patients that has relatively poor PSA responses.
I see.
With the 6 years of the HSPC treatment. If the patient responding poorly, would there be a highly likelihood of there is manageable DNA mutations from that? So this is the things we've been working on. But generally speaking, the timing of the DNA testing would be the mCRPC phase. And to counter the issue that we were talking about, that the sample quality may be suboptimal, there is one way that we have been currently working. It's not been completely fulfilled, but the thing we've been working is talk to the patient that they will know that there is an option that at the time of the diagnosis, when he was doing the systemic biopsies, they can talk to a lab that can do the early DNA extractions. The fee is not that high for the DNA extraction. They do the DNA extraction, they keep it in the freezer and just wait. At the time of the mCRPC, we can go back to their DNA samples and do the DNA testing. That may be the possible alternative to counter the way that we're currently working.
I agree. Yeah.